Today. Good evening, everyone. Welcome to the COVID session, our weekly sessions. And this time, we apologize for a slight delay in starting today. We have the pleasure today of having a distinguished speaker today from all the way from Florida, USA, Dr. Mitchell Yass. Dr. Yass is a well-known physiotherapist. He graduated from the sunny Brooklyn Health Center with bachelor degree in physiotherapy and earned his doctorate in physiotherapy from New York Institute of Technology. And I was just going through Dr. Yass's history. He has a very interesting history of how he got into physiotherapy and how after getting into physiotherapy, he realized that how people were misdiagnosed with during their evaluation and how he felt that muscular causes were an important cause of physiotherapy. I'll not give away more. I would request Dr. Yass to please present his method, that is the Yass method, and enlighten about his way of approaching patients, about which he's been very vocal about. Dr. Yass, please. Thank you.
Thank you. Thanks for having me. I greatly appreciate this opportunity. I have been diagnosing and treating pain for over 27 years, and my primary concern about how diagnoses are achieved is that it's primarily achieved through diagnostic testing like X-rays or MRIs. And very early on in my career, I was looking at certain instances that would occur. For instance, one of the very early on instances was that my father would play tennis on a Saturday, and then on Sunday he would have massive lower back pain, and he'd be bent forward and to the side, and he'd be unable to stand up. And this would happen over multiple months. And so, of course, he felt that he needed to seek attention, find out what was going on. So he got an MRI, and it showed that there was a herniated disc. So by correlative theory, the idea being that he has this symptom, a herniated disc is identified, therefore the herniated disc is asserted to be the cause of the symptom. Well, at this point, I had just started medical school. And so I had learned that if a hip flexor goes into spasm on both sides, it would pull you forward. But if it went into spasm on just one side, then it would pull you forward into the side that the muscle had shortened. And it appeared that that was exactly the way my father was presenting. So I very nicely asked my father, would he mind if I tried to figure out what was causing his symptom? And so I was able to palpate, feel for the hip flexor, the psoas muscle. I released it, and he stood up without pain. And we were both amazed by the fact that I was able to establish that the actual presentation, pain at the lower back, combined with an altered posture, was a representation of a single-sided psoas muscle in spasm. So we did this a couple of times, and each time I was able to resolve it. Then I began to recognize that if I wanted to stop this from happening, I was going to have to stop the muscle from shortening, so I was going to have to strengthen its opposing muscle, which happened to be the gluteus maximus muscle. And from that point forward, we did that, and we were able to stop this cycle of him playing tennis and ending up having pain. And it was this process that started me saying to myself, you know, I understand that people are getting MRIs, and there is this very high percentage of people who do show up with all these structural variations, but it's simply correlative theory that is creating the assertion that that is causing the symptom. So that's how the whole process began. And over the 27 years I've been doing this, I've come to a recognition that, in fact, it's a baseless premise. And so here I wanted to talk about this idea that everybody believes that the MRI and X-rays are so strong in their ability to diagnose the cause of pain. And here's the primary reasons why it's actually completely baseless. So from a theoretical perspective, the idea of using an MRI is based on correlative theory, which is simply to say that if a symptom exists, regardless of the symptom, you find a structural variation for its first time, it is asserted that the structural variation is the cause of the symptom. The way to immediately discount that premise is, well, I can assure you that the MRI will find that that individual has two elbows at the time they're having pain. So then if that's true, then why isn't having two elbows the cause of pain? The bigger picture you can see this in is the idea that if I open my front door, when the sun rises, I can now say opening the front door causes the sun to rise if you use correlative theory. So that in itself shows that that theoretical basis doesn't match. The next concept is, well, from a, we look at, this is the biggest issue that I came to recognize, and it kind of related to what happened with my father. In my 27 years of experience, I have found that in 99% of cases, the place where the person was having the symptom could not have been created by the structural variation that was identified, because every cause has a very specific symptom. So I gave some of the examples. If we look at pain around the kneecap being associated with a meniscal tear, well, if you look at the knee joint is comprised of two joints, the joint between the thigh bone and the lower leg bone, and the joint between the kneecap and the thigh bone. Well, the meniscus lies in the joint between the thigh bone and lower leg bone. So if it was to elicit pain, it would have to create a symptom at that joint, the joint between the thigh bone and lower leg bone, which would be related to the joint line. There is simply no possible way that that meniscal tear can cause pain at the other aspect of the joint between the kneecap and the thigh bone. It's simply a completely different joint. It's like saying a structure at the ankle can create pain at the elbow. Another possible one we talk about is this very common cause that leads to hip replacement is pain at the groin. And it's asserted that since arthritis is identified at the hip joint while the groin pain exists, that means it's coming from that. Well, if you have a situation where someone's saying that, then for me to incite that groin pain, if it was from arthritis in the hip, I'd have to compress the hip joint. And you should feel the pain refer to the groin. And over 27 years of doing this in thousands of cases, I've pressed on the hip joint and I cannot refer the symptom there. But if I do press in the groin area and I can bring on the symptom, that's what's known as point tender pain. And that's a representation of the tissue that I'm pressing on is the tissue eliciting the symptom. And in most cases, it's a muscle called the sartorius muscle or the gracilis muscle. So here again, we're looking at the fact that the symptoms, the presentation of where the symptoms are and how to bring on the symptoms doesn't match what the structural variation is that's supposedly creating it. And that's my biggest qualm, is that over this entire period of time of me interpreting symptoms, where the person is being told that the cause of the symptoms is coming from could never create the symptom in that location. So we have a theoretical problem, we have a clinical problem, and then finally we have scientific studies which have shown that there's a complete lack of basis for the use of the MRI. The very first study that was done regarding people who had absolutely no lower back pain in 1994 showed that almost 80%, over 70% of the population who have no back pain have herniated or bulging discs. Now, when you want to look at it from a scientific or theoretical basis, a study basis, the idea is that for every hypothesis, there's a null hypothesis. So if you're going to tell me that the hypothesis that was created by the use of the MRI is the idea that herniated discs cause pain, the null hypothesis must be those people who do not have pain do not have herniated discs. Well, here this study showed that over 70% of the population without pain does have herniated or bulging discs. Another interesting study that was done was the one regarding knee pain and meniscal tears. It showed that of the people who have knee pain, 63% have meniscal tears. Of the people who do not have pain, 60% have meniscal tears. This certainly goes against this premise of hypothesis and null hypothesis. A more recent study showed over the age of 60, people without back pain, 90% of them have bulging or degenerative discs. And I gave the information about where these studies were. If anybody wants to look them up, you can read further into the way these studies were done, all this type of stuff. One of the more interesting ones that was done was this one about compression fractures at the thoracic spine causing mid-back pain. And so here, this was actually a study done based on a surgical procedure to supposedly resolve the compression fracture. And basically what happened was they took everybody in the study, had compression fractures, everyone had mid-back pain, they split them in half. One group got the vertebroplasty, which is to stick in the cement in to resolve the compression fracture. The other group got nothing. There was zero difference whether you got the actual cement or the placebo surgery. That should make it clear that clearly the compression fracture could not have been the cause of the symptoms. So this is trying to show that in all three cases, theoretical, clinical, and scientific, there is basically no reason to accept the idea that the MRI is identifying the actual cause of symptoms. And I understand that this is something that most medical practitioners have never heard. It certainly goes against the educational training that most people have gotten, but I've came from a theorist background. My father taught me analytical thinking when I was a child, so I simply just don't accept things for what they are. Either they're logically based or, in my mind, they're just not valid and there's really no way of accepting it. So that's kind of, I just wanted to get across what led me to say, you know what, I can't accept the education that I was given. So then I went on and I started my path into trying to establish, well, what is there an actual way of interpreting what the cause is, what the structure is that's in distress eliciting the symptoms? And that's how I developed this method. And the method is primarily based on the idea that every cause sets a very specific set of symptoms. So, for instance, most people recognize that palpitations represents something wrong with the heart, pain at the left arm and the chest. The entire left side of the body going numb, or you can't move your extremities, things like that, represents that the brain is in distress. Difficulty breathing and upper back pain represents pneumonia of the lung. So the idea of diagnosing should be based on the idea that we're trying to establish what is the tissue in distress that's eliciting these symptoms, so the appropriate intervention can be performed to allow that distress to be resolved. And at the end, when in fact the distress is resolved, that tissue no longer has to elicit the symptom, which ends the symptoms, whether it's pain or other type of symptom. So the goal is not to address symptoms. That's foolhardy, because you can try to minimize symptoms, but until you identify the tissue in distress and resolve the distress of that tissue, you're never going to actually resolve the cause of the symptoms. And that's what this is all about. Establish cause, resolve cause. So in evaluating symptoms, I started recognizing that there seemed to be a very high percentage of these symptoms that were associated with muscle. And I started recognizing that through this evaluation, this interpretation of the symptoms, I was able to determine it was muscle. So the 4 types of muscular causes that I was able to establish were: 1, a muscle just simply strains and elicits pain, or it might cause another muscle that's working to try to respond to that, and it strains, so you have actual muscle that's straining. We might have the muscles that attach to joints that have a weakness or imbalance, which will cause a misalignment of the joint surfaces, which will lead to joint pain. This is the classic example of that pain around the kneecap. There's nothing wrong with the structure of the joint. I don't care if arthritis was found. Just because it's found does not mean it's the cause. If I can find that there's some sort of weakness or imbalance of the muscles that position the kneecap, there's a higher probability that it's a muscular cause creating a joint-related pain. One of the other things that I don't think people fully understand is that muscles can refer symptoms, and the greater indication of that is the fact that when you're having a heart attack, you have pain at the chest and the left arm. There's nothing wrong with those areas. It's simply that the heart is referring that symptom. Well, the heart is a muscle. The example I like to use most about that is that person who says that when they sleep on their shoulder, they wake up and their hand is numb. And there's this natural rush to, oh my God, that means that there's some sort of cervical nerve impingement or something like that. That's not what it is at all. What's happening is that the shoulder is being drawn forward when they're laying on it. The rotator cuff, which attaches from the shoulder blade to the arm, is becoming overstretched, and in becoming overstretched for a sustained period of time, strains. And when it strains, it refers symptoms to the hand. So that numbness that's being felt is actually directly being related from or referred from the muscle itself. So this is a case where we have a muscle referring a symptom. And then finally, the last and fourth type of muscular cause is a muscle that strains and impinges on a nerve. That is the classic description of sciatica. People are told that sciatica comes from the lumbar spine, herniated disc, and all this other type of stuff. Well, the sciatic nerve begins in the gluteal area and ends at the back of the knee. So if you're to have sciatica, you must irritate the nerve within its path, the gluteal region to the back of the knee. There is no connection of the sciatic nerve to the spine. So you would need to find where the irritation is coming from, and it's from a muscle called the piriformis impinging on the nerve. So here's a muscular cause creating a neurological symptom. One of the things I started to recognize was that people were describing, when you're doing an evaluation, you want to try to ask lots of questions like, for instance, what brings on your symptoms? Tell me about how this whole started, things like that. And you start hearing the same type of stories. If I sit for a while, I get pain. If I stand for a while, I get pain. If I go up a flight of stairs, I get knee pain. If I try to kneel down, I get knee pain. If I stare at my tablet or my phone, I get neck pain. And so when you start connecting the symptoms being derived from an activity, that should be a red flag that the high probability is that you have a muscular deficit. Because what tissue is responsible for function? It's muscle. So that's another important thing to recognize. I'm going to go through all the components as we move forward as to what the types of symptoms are, correlative symptoms that would show you that it's muscle other than just the pain itself. The general premise as to what's going on, why does it seem that in my presentation, in my experience, that 98% of cases are muscular, relates to the idea that we live in a gravitational environment. So there's always a force being applied down to you. So whenever you're doing an activity, you're pushing up against the force. And it is the muscles that are responsible for creating that force. Ultimately, if the force output of the muscles responsible for the activity is less than the force requirement, how much force is it going to take to do the activity, then those muscles will break down. That is the core overriding reason why most people have pain. So the big question would be, okay, well, if that's true, why now? If you're telling me that the cause of most pain is that the force output of muscles is less than the force, gravity hasn't changed in the history of mankind. What has changed? And why has chronic pain only existed in this period of time from the 1980s and 90s forward? And there's one simple answer. It's technology. Phones, computers, animatronics, everything is leading to less and less requirement for people to use their muscles. If you go back in the history of mankind, you would see who typically was associated with pain. It was older people. Young people, 20-year-olds, 30-year-olds, 40-year-olds didn't have pain. It was older people. Why? Because they retired. And when they retired, they started doing less and less, which made them more susceptible to straining their muscles when they did try to do something. Well, now I treat teenagers. I treat 20-year-olds. I treat people in their 20s in college who can't sit and take a course because they're having massive sciatica, and they're wondering what's going on. And the answer is, well, you don't walk, you don't climb stairs, you don't do anything. You take an elevator. Geez, at this point, even if you want to turn your TV on and off, you got a remote control you talk to. You don't even have to use your thumb to use the remote control anymore. Now we just talk to it. So That is the primary thing that I came to the realization as to why chronic pain has only existed in this period of time from the 1980s, 90s forward. It's technology. It's the same reason that has been given for the non-evolutionary types of diseases such as type 2 diabetes, cardiovascular disease, and obesity. People have already recognized that it's the sedentary lifestyle which has led to these diseases which really never existed prior to this period of time. Well, pain falls into the same category. The last point that I wanted to point out is that if in fact we do recognize that the core reason that people are having pain is this muscular deficit, then there's only one real way that you're going to be able to resolve the deficit, and that is the use of progressive resistance exercise. I believe there's some physiotherapists watching this, and so when you look at what you're educated to utilize when people have these symptoms, there'll be ultrasound, electric stimulation, thermomodalities, lots of types of treatments. In our country, I don't know what it's like over there, they do these needling, dry needling has become a very popular thing. And there's just a cold laser and just lots and lots and lots and lots of modalities. And if you really look at what the modalities are addressing, in most cases, it's still just the idea that they're addressing symptoms. But if you recognize that the pain is being elicited from the muscle, then you have to recognize that the core reason is simply the fact it just doesn't have its force output. And so it's going to continue to strain. Well, in that case, we're going to have to, if this is force output and this is force requirement, I'm going to have to push the force output up above the force requirement for me to be able to perform my activities without straining or eliciting pain. Because this idea has not been recognized, I can tell you now that in the people I've spoken to, and because of the fact that my books are sold by Hay House, which is sold here, Canada, England, Australia, India, and South Africa. I write for an international magazine, What Doctors Don't Tell You. I've really started promoting my method through YouTube. I get contacted from around the world pretty extensively. And I can tell you that most people will tell me the few people they know that have gotten better is not from any treatment. If this is where the situation lied, where their force output was less than the force requirement and they're having symptoms, nobody knew to do this. So you know what they did? They did this. They reduced their force requirement by stopping living. They stopped walking. They stopped playing sports. Many people have been forced to retire. They don't play with their kids or their grandkids anymore. So they reduced the force requirement until the lower level of force output could at least address that so they don't have pain. But that's not what this is about. If you're in my mind, and this is how I feel very, very personally about this, I've dealt with a lot of suicidal people. Pain has an unbelievable effect on emotion. And because of this awareness that has developed, I get contacted a lot by people telling me straight out, I'm going to put a bullet in my head tomorrow if I do not have this resolved. You are my last resort. So this is a very serious thing for me. And so everybody is looking to have the life that they had before their symptoms began. It is not simply the resolution of the symptom that they're looking for. I can tie you to a couch for whatever period of time, you will have no symptom, but that is not why you sought medical assistance. You sought medical assistance because that symptom is preventing you from doing something. And the goal of the diagnostics and treatment is to return the person to full function. The only true measure of success in treating people for pain or other symptoms is return to full function. All right? So that's kind of just a general overriding background to this whole thing. I'm going to try to briefly, I got maybe another half hour. That's not too bad. So we're going to talk about, the goal for today was to talk about the lower back and the gluteal region and how the Yass method works. So I just want to start by pointing out that the lower back begins at the bottom of the rib cage to the top of the pelvic rim. The reason I'm going to point this out, and people say, well, we don't need an anatomy lesson, is because I have dealt with so many people who had pain above, let's say, the bottom of the rib cage, and were told that's their lower back. and allowed the cycle to go on to where an MRI found some lumbar disc herniation or stenosis, and that became the diagnosis for that pain, which was in the wrong area. It wasn't in the lower back region, and therefore that lumbar type of structure could never create it. I have treated innumerable people, which we'll talk about the gluteal region. The gluteal region actually begins right below the pelvic rim. So you might have pain all the way down here on the back, and I'll show you where that is. And again, because it's so close to the lower back, and because the typical medical practitioner has not been educated to really understand how to differentiate these areas, they're going to be told that that could be coming from the lumbar spine. Get the MRI, find the structural variation, boom. Surgery, fusion for pain in the butt that could never have been created from some structural variation at the lumbar spine. So that's why I'm going to try to show you, number one, the very first thing I do when someone says they have lower back pain, I put my hands, or I tell them to put their hands on their pelvic rims, and I say, if this is your fingers on your back, create a line from thumb to thumb, and then tell me, is your pain above or below that line? If it's above the line, we're talking lower back. If it's below the line, it's the gluteal region. And until you can differentiate that, I'm not quite sure how you're going to be able to start this process of identifying which tissue, if it's muscle or whatever, is responsible for eliciting that symptom. So that's the first step, is to understand where the lower back is. The next thing to understand is that the typical person has pain on one side of the lower back or both sides of the back. And I don't know if people recognize that that is an actual separation of symptom. One-sided lower back pain has a separate cause from both sides. So you're going to have to make sure that you're understanding whether the person is saying that their pain is on one side or both sides, because we're going to have to look for two different causes. The other differentiator is whether the pain is more centralized, very, very close to the spine, or whether it's off to the side, 3 or 4 inches, 2 or 3 inches. Now, if you kind of look real close here, you're going to see that you got this massive band of muscle here. This is the psoas major, and it attaches to all 5 lumbar spine. So the person is telling you that they have centralized pain, and they might, they're kind of swiping, so they might not be so accurate. But if they're looking like they're looking very close or pointing very close to the spine, just remember that the psoas muscles attach to all 5 lumbar spine. So if that muscle was to go into spasm or strain, it's going to pull excessively on its attachment to the 5 lumbar spine. Now, the critical thing to understand is that if it was the actual vertebrae itself, what would cause a bone to elicit pain? It's got to be fracturing. But the bone has periosteum surrounding it, and the muscle attaches into the periosteum. So what you're really experiencing is a release of pain receptors in the periosteum from the excessive pull of the psoas muscle. So don't jump to the conclusion that just because the person says they have this centralized pain, oh, it must be from the spine itself, the structure. The psoas muscles attach to all 5. And I'm going to show you how there are specific symptoms that we could look at to confirm that it's actually the psoas muscle and not the structure. When we go off to the side a little bit here, we can see that this is the actual quadratus lumborum muscles, and that's the muscles, the low back muscles, and those attach from the bottom of the rib cage to the top of the pelvis. So if the person says their pain is 2-3 inches off to the side, we're going to probably see that it's from the psoas, from the QLs, quadratus lumborums, okay? So we're now recognizing that they have pain, and whether it's centralized or off to the side, whether it's on one side or the other, we're going to start to look for corroborating indicators that it's muscular. Number one, we're going to determine if they say, we've talked about their history, oh, I get my pain if I sit too long, if I stand too long. Wow, while I'm working, I start to get the pain, and after it gets worse, right? So if we're describing an activity, you have to immediately see that as a red flag that the cause is most likely muscular. Here's another very simple type of thing. The person has had writhing pain in the night, and they say, God, I take a hot shower, I feel great. Well, if heat or massage reduces the symptom, the odds of it being stenosis or a herniated disc or arthritis kind of should go out the window, because I can't imagine heat or massage is going to make the arthritis disappear, unstenosis to stenosis, or shift the disc, right? So that's a nice question to ask somebody. What makes your pain better? Well, if they're telling you, hey, a hot shower, I get it, right off the bat, that's a very positive sign that it's muscle. Number 3, it's worse at night. This is the one that kind of confuses people about muscular causes, because you would think that if you're doing activity and the muscle strains, that you would expect the pain to be at the time of the strain. Well, here's why that doesn't happen. When you're doing activity, muscles are contracting. A byproduct of muscular contraction is lactic acid buildup. Lactic acid will build up and convert the pH of the blood to acidic, and the body never wants that to happen. So it's going to take blood and push it into the area where the lactic acid is developing, so that that lactic acid can be brought back to the liver and converted. Well, blood is warm. Well, in the blood being warm, it can keep that muscle nice and long, even though it's strained and it's going to want to have this contractile shortening. It's going to have difficulty doing it while it's active, because you've got this warm blood in there. Remember, warm causes distensibility of muscle. So that's why, even if the person strains, that's the classic example of like tennis elbow. Oh, I have massive pain. I play tennis. I seem to be able to get through it. And then after, the pain comes back. That's the idea. The idea is while you're doing the activity, muscles are being kept warm by lactic acid development, forcing blood into the area. Blood is warm. What happens at night? You're not doing activity, no lactic acid development, no reason to get blood to the area. Now that muscle has its tendency to want to shorten because it's strained. Pain receptors run along the lengths of muscle fibers. So let's say the proper length of a muscle is this long, and you were supposed to have 10 receptors, and now it's shortened because it contracted and strained. You've just concentrated those pain receptors. So that's why pain at night typically is a true good indicator of a muscular cause. Now we could look at other types of things. So we're looking at the lower back. People always think about, oh, pain is the only type of indicator. Well, if in fact it's muscle, muscles are responsible for the position of bones. No bone arbitrarily determines its position. Bone position is based on the pulls of muscles attached. So if we see a change in posture, let's say that this psoas muscle or this QL has shortened severely, based on the fact that it's attached to the posterior pelvis, it's going to pull that pelvis up, and it's going to take what would be a normal, very mild lordosis or curve, and it's going to make it extreme. So a severe anterior tilt could be an indication of a muscular cause of pain. A posterior tilt is another one, and these relate to if you're having pain on both sides of the back. If you're having pain on one side of the back, you might be looking for a tilt in the pelvis from side to side. So let's say that this side of the pelvis was higher than this side. That's a change in posture, which is going to indicate that the muscle's responsible for the pelvis being level, which is the gluteus medius muscle, and I'll show you that in a minute. That's strained, and as a result, once the pelvis is higher on one side and lower on the other side, the quadratus lumborum, a lower back muscle on the drop side, is going to be asked to try to contract to pull up to compensate for the weak gluteus medius on the opposite side. Well, that wasn't designed to do that, so that QL will strain and eventually shorten, pulling the pelvis up on the shortened QL side or on the opposite side from the weakest glute med. So an altered posture of the pelvis will be a fantastic indicator, along with the pain, that it is a muscular cause. Oops. Let's go down to loss of range of motion, bending forward. This is for the person who has the pain across the back. If they try to bend forward, you should be able to see that the lower back goes from a concavity to a convexity, an arch to a hunch. If the person bends forward and you're still seeing some level of concavity or arching, it's telling you that something's impeding the range of motion of the back to go from this arch position to this hunch position. So a change in a loss of range of motion due to a lack of ability of the lower back to go from an arch to a hunch is another indication. Then one of my favorite aspects is palpation, touching. if you could bring on what is known as the comparable sign, the actual symptom that the person's having, then that is a critical indicator that you know what tissue it is. So I pointed out this relates to point tendon versus referred pain. Someone has said that pain off to the side here is coming from a herniated disc or stenosis because they found that in an MRI. Well, if that was true and the pain is 3 to 4 inches to the side, where would I have to press if it was coming from stenosis or a herniated disc? I'd have to press on the spine, and they should feel the symptom refer. But what if I go 3 to 4 inches off and I kind of press right where that QL is attaching into the pelvic rim, and I bring on the symptom? Well, I just showed that the symptom is point tendon, meaning that the tissue I'm pressing on is the tissue eliciting the symptom, which just refutes, completely eliminates any structural variation that was identified as the cause of symptom. My point to everybody is the fact that just because some structural variation is identified does not mean that it is the cause. Just a brief note, in 2007, the American College of Physicians does a 40-year literature search and finds that most people who have lower back pain can be put into a category of non-specific back pain. They find that 85% of the people seeking care have non-specific back pain. They established that MRI studies did nothing, not one thing, to improve outcomes relating to non-specific back pain. And in fact, it led to surgeries and procedures that were unnecessary. This is the American College of Physicians wrote that position paper. If you simply replace the word non-specific with muscular, you'll start to understand why all the treatments relating to the spine didn't work. Okay, we're going to continue on, a couple of more. So if I'm looking at posture, I think, let me just go back. Did I mention the posture? The forward center of mass. When we're talking about the anterior tilt, one of the things that you're going to look at from the person on the side, if they're having pain across the back, is where is their ear in relationship to their ankle. If you have proper posture, your ear should be directly over your ankle. If you have an anterior tilt where the muscles are leading you forward, causing lower back pain, you're going to find your ear is closer to the balls of the feet. The person will feel like they're weight bearing more on the balls of the feet. That's another change in posture that is indicative of a muscular cause. Okay, so now continuing, one of the things I like to look at is if it's single-sided, we're going to look at single leg stand, squat, and hop. How do they perform that? Is it more difficult? Is there pain brought on? These are important when it's single-sided because we're trying to establish, and I'll show you that in single-sided, it's typically related to a gluteus medius strain, that there's greater difficulty in weight bearing on one side, which is causing the lower back muscle on the opposite side, sometimes the same side, but mostly the opposite side, to have to overwork to compensate for that. So these are, again, corroborating test indications. And finally, we're looking at muscle testing. So if, in fact, this person has this forward center of mass, they have all these things, they're having lower back pain across their back, and I find that their quads are much stronger than their hamstrings, then that's going to help me to recognize that the quads being stronger have shortened, and because they're attached to the pelvis in the front, they're going to pull that down. That front of the pelvis being pulled down causes the back of the pelvis to rise, causing excessive anterior tilt, causing shortening of the lower back muscles and psoas muscles. So this understanding of muscle testing is another corroborating find of a muscular cause creating the lower back pain. On the single side, we're going to test the gluteus medius, and right here is the gluteus medius muscle. It sits on the side of the pelvis and attaches to the hip joint. It's responsible for keeping the pelvis level, and in most cases, as I said, that single-sided lower back pain, that's going to be caused because the pelvis is not being able to be maintained level. One side is going to drop. If this side were to drop, the distance between the hip and the floor shrinks, and you're going to have difficulty pulling your leg through, which means you're probably going to have tripping occurring. The body wouldn't let that happen, so it's going to ask the lower back muscle on the opposing side to pull excessively to counter that, and that could lead that to strain. So the common causes of lower back pain when it's on both sides are an imbalance between the hip flexors and the gluteus maximus, or the quads and the hamstrings, And the single side, the primary cause, is the strained gluteus medius muscle. So that's a representation of how the Yass method works to corroborate cause and confirm it's muscular in nature. Okay, now we'll go to the gluteal region. The gluteal region, again, I want to point out, begins at the top of that pelvic rim. So if you want to differentiate, if someone's saying they're having pain and you say point to it, you want to have them put their hands on the top of the pelvic rim, have their thumbs running across it. Above it is the lumbar region. Below it is the gluteal region. If you look at this, you can kind of see right here, this is the gluteus maximus. It runs all the way up to the pelvic rim and wraps around from the top of the pelvic rim to the bottom of the sacrum area, all the way across to the hip joint, right? So just think about that. That's your gluteus maximus muscle. So that's where it begins and ends. There's pain. Typically, it's across one side. Rarely is it both sides. And the pain is typically going to be in the upper gluteal region, kind of where the top of the sacrum is. And the other area is in the lower gluteal region, which is where the hamstring attaches. So the two typical areas of pain are the upper gluteal region near the top of the sacrum, or the kind of in the inner point of the pelvic rim where it starts to reach. This is very funny because this is where the magical SI joint dysfunction comes from. Everybody with pain in this area is going to be told they have SI joint dysfunction. I want to just briefly hit this because this is a very, very common. So the person has pain there. Maybe some x-ray shows that there's some arthritic change at the SI joint, and boom, that becomes the cause. Correlative theory. Joints are designed to create range of motion. So if you want to tell me that a joint has dysfunction, which leads to distress, which leads to eliciting pain, well, then you're going to have to show me that there's some loss of range of motion. A joint's only going to elicit pain if there's loss of range of motion. Well, the purpose of the SI joint typically is to allow for knee flexion, extension, and hip abduction and adduction. So the way that you could diffuse this idea is I have the person raise their knee on the unaffected side and bring it down, and then I have them separate their legs. And I see that the range of motion is basically the same on both sides. If that's the case, you cannot tell me that the cause of pain is SI joint. And they even use that just generic word, dysfunction, which really doesn't mean anything to me, right? So I want you to think about that. It's the SI joint. If it's the SI joint, you're going to have a major loss of range of motion. The point to be made about it being muscular is the idea that the piriformis happens to attach right along and crosses the SI joint. So it's more apt to be the muscle. And if we do palpation, we can see that pain can run away from the SI joint, which reinforces the point that it's the piriformis muscle. Okay? So the other point to be made is that if you look at everything that is in the gluteal region, it's all muscle that leads and performs function at the joint. So I'd like people to start thinking about the fact that if there's pain in the gluteal region, it is not related to the spine, the sacral spine. It is most likely associated with hip dysfunction, meaning that there's some muscles that are associated with the hip's ability to perform function that is leading to the pain. If we just go through the cycle again, we want to know that the symptoms are associated with activity, that heat might bring it on, make it better, that at night it's worse. We're looking for changes in the pelvis. Palpation, we're looking to feel for the gluteus medius muscle, the piriformis muscle, the hamstrings to confirm which of the muscles. We're going to do the functional testing. We're going to see in walking, is there some sort of change in the step length or the cadence? Someone who's having pain on the left side is going to try to get off that foot very quickly. So the time that they spend on that foot is going to be shortened. So the step length on the right side, if it's a left side pain, is going to be shortened. So if we see a change in cadence or step length is going to be a factor. Single leg stand, squat, and hop, same thing. Testing, muscle testing, and then finally flexibility testing. If it's in the bottom of the gluteal region, we want to see what that hamstring length is. And from that, we're going to be establishing whether it's strained. And if it is severely strained, we're actually going to want to strengthen the quad and until we get the full length of the hamstring, and then strengthen that. So the primary causes of pain in the gluteal region is a strained gluteus medius and hamstring. I think I tried to get that done in a reasonable amount of time. Hopefully I did. I think we can open it up for questions now.
Yeah.
Why don't we go from there?
Yeah. Thank you, Dr. Yass, for a very interesting and a very passionate talk. We really can make out that how strongly you feel about this. You really broadened the horizons regarding this topic. We never really thought that muscle can be an important cause for pain, and we've always been looking at the MRI and the X-rays. We have a couple of questions. I would like to just bring up them. I would actually request them to bring it up themselves. Dr. Dharmanand wants to ask, sir, can you, if you could ask yourself, sir, I'll unmute you.
Hello, Dr. Yass.
Yes.
Fantastic talk, and we enjoyed the talk. I want your opinion on why some people develop a trigger points in a muscle. Is it due to a weak muscle which is under strain, develops a trigger point, sometimes which radiates pains to other regions?
So, so the trigger point thing is a really, really good question. I like that one. And unfortunately, because the trigger point has been identified and talked about, people think about the idea that we want to try to address the trigger point itself. The trigger point is, in my mind, okay, so the understanding of what happens when a muscle strains. So muscle has fluid in there called sarcoplasm, and it acts as a lubricant because the muscle contracts by actin, by myosin, which is basically a set of golf clubs grabbing golf balls, which is the actin. They pull each other along each other, which is called the sliding fiber theory, and that's how contraction and force is created. My belief and my theory is that when a muscle contracts, the body does not want that muscle to tear, so it creates this protective mechanism where the fluid actually converts to an Elmer's glue-based substance. And in doing so, it binds the fiber together. If the fiber is bound together, it cannot create its optimal force and therefore tear. So my opinion is that straining is the body's attempt to protect against tearing. So when we look at this area, which is all gluey, what you see is you have this bunched up fiber, and since fiber has pain receptors in there, it's actually got a very high level of pain that can be experienced. So my opinion is that these trigger point areas are just highly dense muscle fiber, which has been bunched together by this gluiness. I attempt, if given the opportunity for the person to be seen in person, I massage out that area with the understanding that what I'm trying to do is trying to release that gluiness. Remember, the gluiness occurred because it was a response from the brain to try to say, I don't want it to tear. So in releasing the knotting, and you will literally feel over a very short period of time, my massage is no more than about 30 seconds, I can feel it release and go away. The fascinating part is that, and this is how I started developing this, what were the three things I established immediately after this? After I felt the knot resolve, there was decreased pain in the area, increased range of motion or flexibility of the muscle, and increased muscle force of the muscle instantly without me making any kind of muscle mass or doing exercise. So that brought me to the realization that these trigger point areas really are just bunched up muscle with this thickened material holding it together. And if I release it, I can now resolve the pain, increase flexibility of the muscle, and increase force output. And what's fascinating is I could have a person who might have difficulty single leg standing. By just doing the massage, I will then have them try to single leg stand again, and they will improve with less pain. That's before I've even begun to try to grow muscle mass. So it seems to really reinforce my position that these trigger points are just bunched up muscle that have this gluiness, which was the result of the brain's attempt to prevent against tearing by creating the straining and thickening of this fluid.
Yeah, thank you, sir. There's one more question by a physiotherapist. Vinil, if you could put up your question. I'll just unmute you.
Yes, sir. Hello, sir.
Yes.
Sir. Hello, sir. Wonderful to have you, sir.
Thank you.
Yeah. So, sir, so to what extent is the posture and the low back pain is related? So, like we recently went through some papers, they say that the best posture is your next posture. So, what is like, how do you take it, sir? Like, does the posture actually play a major role on the muscle?
Does the posture, what was the question? Does the posture?
Does the posture affect the muscles?
Does the posture affect the muscles is the question?
Yeah, yes, sir.
Yeah, so it's, okay, it's really important to understand that bones, and this is kind of, I mean, it's just, you just have to be somewhat rational and logical about the idea. Just as the kidney, the liver, or the spleen is not in a position to change its position, nor can a bone change its position. It's innate. It simply is. The only tissue that has its ability to change its basic morphology, its length, its force output, anything other than that is muscle. And so when we're talking about posture, this is really critical when we're looking at scoliosis. This is one I'd love to hit home with people. So scoliosis is such a popular issue when it comes to back pain. And so there's this perception that if I see this curvature in the spine, that the goal should be, if I want to resolve the pain, is to correct the spine. So people are given braces, and in very dramatic cases, they have rods put in them. What you want to understand is that that bone variation didn't occur on its own arbitrarily. It's based on the muscle pulls or the forces that are attached to the bones. So this, if you get this one, this will, I think, really help you tremendously. Remember we talked about that the pelvis has to be maintained level? Well, if the pelvis is maintained level, then the spine remains perpendicular to it. If the pelvis drops to the side, the spine cannot remain perpendicular because it's sitting on the foundation of the pelvis. So it's going to move to the side. Well, nobody's going to walk like that. They're constantly going to be trying to move upwards and back upright. And so that's going to lead to this curvature. So my opinion is that a very, very, very high percentage of scolioses are associated with an altered pelvis that's no longer level due to a weak gluteus medius muscle. So just remember, because the pain and the scoliosis are identified at the same time does not mean one is causing the other. It's actually both are symptoms representative of a muscular cause. And in most cases, it relates to, if you find that the pelvis is not level, you're going to want to assume that some change in the way the spine is responding to the pelvic position is what's causing this change in the way the spine appears. So scoliosis is very strongly associated with muscular deficits. I could just briefly, I know you want to get questions in, but I had a lady who had pain between her shoulder blades, and she was told she had a severe kyphosis, and so they put a rod in her, and she ended up still having the same exact pain between her shoulder blades. And if you looked at her posture, it wasn't just that it was kyphotic, it was very round-shouldered, very forward-shouldered. And if you looked at her shoulder blades, they were very, very far away from her spine. And when I actually palpated to feel, you felt that the pain wasn't coming from the vertebrae itself, the thoracic spine. It was where the interscapular, the rhomboids and mid-traps were attaching in. And so all I did was strengthen up her upper back, mid-back and mid-back muscles and rhomboids, her mid-traps, her lower traps, her posterior delts, her rotator cuff, pulled her shoulders back. And within a very few weeks, she was pain-free. And that's very disheartening to somebody like me. This poor woman, she was in her 30s, got a surgery she never needed. And that's the kind of stuff that's very concerning to me. I don't want anyone having a single surgery that's not necessary. If it's a muscular cause, no surgery will correct that. If it's a structural cause, no exercise is going to correct that either. You got to go both ways. But the only way to identify it is through a proper evaluation, which has to be physical in nature, trying to evaluate the symptoms that are representing that tissue in distress. So hopefully that answers your question about posture. Posture follows muscular causes. Muscular causes do not follow posture.
Thank you, sir. Thank you for that very elaborate answer to that question. Next, we have again a physiotherapist, Mr. Prem. If you could please ask your question.
Yes, that was a good talk, highlighting the role of muscle as a pain generator. Can you can you tell us about your approach towards core muscle strengthening? How do you do it, or no? What is your take on it, on back pain?
What was the question on how I treat back pain?
Yes, with core muscle strengthening.
Oh, cool. Okay. Oh, did you say mention core strengthening?
Yes, yes, yes.
Ah, okay. So you're going to find out that I'm no fan of core strengthening. It's kind of a fallacy. It's one of the things that now they got people, they do this, I forgot what it's called now, but they're moving tires and they push sleds in fitness. Core strengthening, as far as I'm concerned, was nothing more than fad. Let me just explain what I mean by that. So the general premise was that since you have lower back pain, if you want to strengthen the opposing muscles, which is the abdominals, somehow that's going to help to create stability. So if we're talking about the abdominal sheath, if you did a cross-sectional MRI, you would see that the abdominal sheath is extremely thin. And if you look at the lower back muscles, they're incredibly thick. Well, the reality is that if you look at the average person, the abdominal sheath is so weak, it can't even hold the abdominal viscera in. That's why everybody has this gut situation. Probably not in India, but boy, in the United States, it's rampant, right? So the idea that it's so weak and incapable of holding the abdominal viscera in tells me that it's probably not going to have a lot of ability to enhance stability of the back. So you certainly don't want, there's no value in that. And certainly if that's true, you would never want to strengthen the lower back muscles, because we know that the lower back muscles are so much stronger than the abdominal muscles that if we strengthen those, we're going to feed into the imbalance, and the low back muscles are actually going to shorten further, leading to greater pain. So when we look at the lower back, we kind of want to look at the idea that if we're looking at pain above the pelvic rim, amazingly, the cause is below the pelvic rim. And it is the relationship of the hamstrings to the quads and the hamstrings. So if the quads are stronger than the hamstrings, they attach to the front of the pelvis, they're going to pull the front of the pelvis down, causing excessive arching. So that will lead to this excessive arching, shortening of the low back muscles, possible straining, right? So conversely, which is an unusual case, if the hamstrings are stronger than the quads, it's going to pull the posterior aspect of the pelvis down, which is going to cause a loss of arch. It's going to flatten, and now the low back muscles become overshortened. Either way, the muscles lose their ability to create force, and so they strain. So when I'm trying to maintain this pelvic level front to back and maintain the optimal lordosis and the distance between the bottom of the rib cage and the top of the pelvis, I'm looking to have balance of strength between the quads and the hamstrings, the hip flexors and the gluteus maximus muscle. And the reason for most people having back pain is the fact that generally we do things in front of us. So our hip flexors and quads are much stronger than our gluteus maximus and our hamstrings. So for anybody, I talk about these as the global exercises. Hip extension, which isolates the gluteus maximus, and hamstring curl, which isolates the hamstring, should be basically done by everybody, regardless of whether you're in pain or not, because the natural tendency is to have this imbalance. And if we could sustain more balance between these muscles, we're going to allow our bones to be at their optimal positions. We're going to allow our muscles to be at their optimal force levels, and that's going to allow us to be able to perform optimally with the least chance of injury. So when we're talking about lower back, to resolve lower back pain, like I said, whether you're in an anterior tilt, the posterior tilt, we want to make sure we have balance between the quads and the hamstrings, the hip flexors and the gluteus maximus. And when we're side to side, single back pain, we want to make sure that our gluteus mediuses are strong and balanced. So that's how I address lower back pain from a muscular position.
Yeah, thank you, Dr. Yass. I hope it answered your question.
Yeah. Also, is there any role of diaphragm in it and abdominals? Do you work on it?
On the abdominals, you said?
Yeah, on diaphragm. Do you work on it? Diaphragm.
On the diaphragm?
Yeah.
I'm not really familiar. And that's not something that I'm very familiar with. Most of the people that I've treated have presented as having specific back pain that I've been from muscular causes. So I really look to address the very, very specific cause of it, the weakness or imbalance that's specifically associated. I'm not really sure how the diaphragm would come into play with that.
Okay. Thank you.
Yeah, sure.
Dr. Yass, I'm a rheumatologist myself, so I have commonly what we come across in clinic is osteoarthritis, where obviously we would suggest some quadriceps or gluteus exercises. So what would be your pearls regarding a patient with osteoarthritis? What exercise to recommend other than these, or these are the enough, or lower back exercises also if required?
So the question relates to osteoarthritis, you said?
Of the knee, yeah. So most
of the knee. All right.
Osteoarthritis of the knee.
Oh my God! Now you're hitting my favorite topic: osteoarthritis. So first off, we have to understand that osteoarthritis is not an inflammatory issue. It's not rheumatoid arthritis. It's not psoriatic arthritis. It is a mechanical wearing down of joint surfaces. You want to try to understand what really happened. So if we look at the knee, if we're talking about the joint between the thigh bone and lower leg bone, we have this position like this. And when our muscles are strong and balanced, we have 100% of the surface area of the femur touching 100% of the surface area of the tibia. And that's all great. That's the way it's designed. But now we get this weakness or imbalance that might occur. And so we get a slight shifting of the bones. And let's say 90% of the surface area is now touching. 90% of the surface area requiring 100% of the force to run through it. That's a bad equation. So what's going to happen is a bit of that hyaline cartilage is going to start to wear down because it's a force it wasn't designed to. And once hyaline cartilage is worn down, you have exposed bone. Once you have exposed bone, you either get bone deterioration or hypertrophic bone growth. That is the osteoarthritic process. It takes years, if not decades, for this to occur. It never elicits pain. I can tell you an amazing story. I was once driving up to a community, and the guard there comes out, and he wants to talk to me, and literally his pinky, you see how my pinky's facing up? His pinky was facing this way, literally 90 degrees to his other hand. And being who I am, I had to apologize for asking, but I said, you got to tell me, man, does that hurt? And he said, not at all, not at all. I just have to be very careful when I'm putting my hands in my pockets that I don't get my finger caught. So these arthritic changes, as a general rule, do not cause pain. And what's happening is, for too many people, is you're seeing an arthritic change and they have pain at the joint, and therefore it's being asserted that that's it. I've seen different books and movies and stories about exercise for arthritis. I don't even know what that means. It doesn't really mean anything. You don't treat arthritis. There's only one condition where arthritis can actually create pain. And as I described, you have that meniscus between there. If that meniscus wore down and you were literally bone on bone, and bone on bone cannot be identified by an X-ray or MRI, they could tell you you have decreased bone growth, but they can't decrease joint space. But they can't tell you you're bone on bone because the human eye can't differentiate 0 from, say, a 32nd of an inch. It's just not possible. So the physical presentation of being bone on bone is where you have a major loss of range of motion, and at the point where that range of motion stops, if you try to go further, it feels like a bone's hitting another bone. In my 27 years and 15,000 people I've treated, 2 people have presented as being bone on bone, and I recommended them get joint replacements. Every other person had full range of motion, and therefore, as soon as I saw that range of motion was full, I immediately discounted the diagnosis of being bone on bone. It was fallacy, simply fake, based on a false diagnosis coming from an X-ray or MRI, which was interpreted by a person who cannot visually confirm that that's bone on bone. So as a general rule, you don't want to talk about treating osteoarthritis because there is no treatment, no muscular treatment. If the fact that the bones are rubbing in an improper way and you're feeling some sort of pain, let's say at the kneecap, I'll give you an example of that. The person bends their knee, and in bending their knee or trying to squat down, they get massive pain around their kneecap. And let's say someone gets an X-ray and they find some arthritic change on the back of the kneecap. They'll say it's osteoarthritis. But now I do all my tests. I muscle test, find the quad is too strong relationship to the hamstring. Flexibility test, quad is too way too tight. I can ask them to try to bend down, and there's too much pain going on there, right? I palpate and I found knots in the quad. All of these things tell me that I muscle test. The quad is too strong. So in that particular case, if I was to simply stretch the quad and strengthen the hamstring, I'm going to elongate the quad, allowing as the kneecap bends, as the joint bends, for the kneecap to glide, not compress. and you'll see the pain will go away fairly instantly. Within a simple stretch can make it go away. So what did that show? Although the pain was at the joint, it was pain associated with some altered positioning of the joint or tension on the joint because of a muscular cause. And although an arthritic change was found, it had nothing to do with the cause. It was actually a muscular cause. So it's a very big jump for people, and I understand that. It's a very big jump for people to say, I see a structural variation, but the structural variation isn't the cause. I understand how hard that is. But I promise you, given enough time with me, you will see that every bit of evidence shows that they are just independent variables, completely independent to the cause of the pain. It can be seen in as many people without pain. So how can we accept that just because it's found at the time of pain, it is the cause? There's too much evidence that shows, and this presentation I'm providing is trying to give you the understanding of how if you follow these steps, you would be guaranteed to see that that knee pain around that kneecap was more from a muscular cause, like the quad being imbalanced from the hamstring, than that osteoarthritic finding. So hopefully that answers your question about that.
Yeah, definitely, Dr. Yass. Thank you so much. I think we have no more questions.
Okay.
Yeah. Thank you so much once again from our side, from the Karnataka Rheumatology Association, for taking time to very passionately discussing this topic and really broadening the horizon regarding this part. We never really thought that muscle could be an important cause for pain. And definitely when we see patients, we'll definitely look from that perspective from tomorrow. And that is thanks to your talk today.
Yeah, I would like to just point out to you guys, and I really am doing this in the sense of wanting to teach and help people so desperately. If you guys decide that you would like me to do this on a more frequent basis, pick different topics, you know, I am really open to the idea of trying to spread this. It's just so critical, because once you experience it, you're going to see it just makes a lot more sense than the way this existing system is working. And that's why there is chronic pain. And when I've spent so much time, this has been my life, 27 years treating all these people. I just don't want to see anyone in pain, because it's not that they haven't put the effort in, not that they put the money in, or they don't have the commitment. It's just because the education or the understanding isn't there. I really believe it's critical to spread this. So I certainly would like myself to be made available. If you guys decide you want to do a monthly type of thing, I'm all good with it. And secondly, please use my YouTube channel, Dr. Mitchell Yass, as a reference. If you guys decide that there's something that you want some clarification on, email me. Tell me you want me to do a video about it, and I'll be happy to do that, because in giving it to you, it's just an opportunity to spread the information to more people. And if you're asking about it in your country, trust me, someone else is asking about it in 100 other countries. So I just want you guys to understand, I'm really open and very, very excited and honored that I was asked to do this for you guys. So please use me as a reference, and definitely, join my YouTube channel. I really want this to get out there and spread.
Thank you, Dr. Yass. We have just one short question. Somebody raised their hand.
Sure.
Can we take one more
Absolutely,
question?
no problem. I'll spend as much time as you want.
Dr. Yass, I'm a rheumatologist, and having seen a lot of osteoarthritis and the different types in India, where squatting is more common than in the West, our carpenters, etc., the farmers who work in the field, squatting is more prevalent. Hence, we see a lot more of the patellofemoral osteoarthritis.
Yes.
And what we have understood so far has been that the main thing to do is, because they do have some degree of quadriceps wasting, you strengthen the quadriceps. Now, what I have heard from you now is you are talking about quadriceps stretching versus strengthening. Is there a difference?
Oh my God, thank you. This is such a great question. Okay, so here's what we want to understand about function of muscle. There's something called the length tension ratio. This is the essence of my entire method of how muscle works. How do you know whether to stretch a muscle or strengthen a muscle? So just imagine we're looking at a chart, and on the side is force output, and on the bottom is muscle length. You would actually see at the very shortened position of a muscle, its force output is very limited. As you begin to lengthen the muscle, the force output begins to rise. At an optimal length, you get an optimal amount of force, and as you continue to lengthen it beyond its optimal length, it begins to lose force. So it's a bell curve. And what you find is that there's an optimal length that creates an optimal force. Depending on which side of that you're on determines whether you strengthen a muscle or stretch a muscle. So let's look at the quadriceps muscle. For you to determine the length of the muscle, the normal length or flexibility of a muscle should allow the knee to bend to 135 degrees. Basically, if we're looking at that, it's where the person can take their heel, bring it to their butt with the knee about 2 to 3 inches behind the hip. And if you guys want, I have in my books, I have pictures of this stuff, I can show it to you, okay? So let's look at a person who, if I said, can you bring your heel to your butt, can't even bend down and reach their foot enough to begin to bring their heel up. You are looking at a severely shortened quad, which means you're to the left of the optimal length and optimal force. If you were to strengthen the shortened muscle, is that muscle going to lengthen or is it going to shorten further? You're going to shorten it further. You're keeping its force output all the way down at the bottom of that bell curve, right? So if you're on the left side and you don't have optimal flexibility of that muscle, which each muscle has a specific range of motion it's supposed to achieve, you cannot strengthen that muscle. You need to stretch that muscle, which is to say you strengthen the opposing muscle, in this case, the hamstrings. So in a case of that person that I just described that doesn't have that full flexibility, amazingly, I'm going to strengthen their hamstring. Correlatively, you're going to actually muscle test them and see their quad continues to get stronger and stronger. Once they have full range of motion, full flexibility, 135-degree knee bend with the knee 2 to 3 inches behind the hip joint, they're going to have the optimal length of that quad, at which time now I can begin to strengthen the quad. Once I begin to strengthen the quad, I can now take it to its optimal force capacity and maximize its function. So this is the piece that I'm not sure really anyone, the crazy thing is everybody learns this in medical school where we are, the length tension ratio, but everyone just takes a test on it and forgets it. It is the core determinant as to whether a muscle should be strengthened or lengthened. The classic other example is the rotator cuff. So if the rotator cuff, you should have 90 degrees of internal rotation if I brought your arm down. If I'm here and I try to push it and it's too much pain, that shows me I don't have the full range of motion of the rotator cuff. Therefore, I can't strengthen that rotator cuff. I'm going to have to lengthen it. The rotator cuff does external rotation. So I would be strengthening into internal rotation until I get 90 degrees, at which time I can then strengthen it. So hopefully, it sounds to me like you got a whole lot of people there with very strange shortened quads, and everybody is assuming the answer is to strengthen it because it's presenting as weak. Don't forget, that bell curve is going to show you weakness can occur either at a very shortened position or at a very lengthened position. And if it's shortened, strengthening it only keeps it short and weak. You're going to have to wait till you get up to that optimal length, which in the case of the quads, as I said, is 135, basically bringing the heel towards the butt with the knee 2 to 3 inches behind the hip. Does that make sense?
Well, that's excellent, because now when you have someone with moderate patellofemoral osteoarthritis, I think at the onset they may not be able to bring their heel up to the butt, but then you've got to keep trying till they get the heel to the butt. I got that bit. Now, at the same time, you were talking about trying to correct the imbalance between the quads and the hamstrings.
Yes.
Now, this is again with reference to patellofemoral. So when you're trying to stretch the quads, what exactly are you trying to do to the hamstrings? Would you do extension of the hip or something like that?
That's called the hamstring curl. It's the exercise where, let's say you had a resistance band and you have it around, the leg is straight out, and now they're bending their knee, pulling their heel back until the heel is directly under the knee.
Right. Now, coming to the strengthening of the quadriceps, the standard teaching or as commonly what the physiotherapists do would be to just flex and extend straightly. But some would advise you need to slightly laterally rotate your leg before you flex and extend. Is that because you're trying to, no.
There's this theory that you're trying to get more the medial aspect of the quad. There's some weird stuff. So what you're referring to is this very common theory that was a physical therapy theory that the vaste medius oblique, this tiny little portion of the quad, which is on the inside, is causing the kneecap to track laterally, and therefore you have to focus just on that. It's just almost, and I don't mean to be disrespectful, but it just doesn't make any sense. Look at the overall size of the quad, and you're telling me that pain is coming because a tiny aspect of it isn't doing what it's supposed to? It just doesn't make any sense. What's happening has to do with the compressive nature of the quad. Here's a great point. I love what we're talking about right here. So you want to confirm that the problem is that the quad's short. The quad pulls up on the kneecap, correct? So if in fact the reason that they're having that patellofemoral pain is because the quad is strained and shortened because it's, let's say, too strong, what if you check the lateral aspect, the lateral patella glide? How easy that patella can move. So on an unaffected leg, we get a certain amount of tension or freedom. If we then check the lateral patella glide on the affected leg, and we know that the quad is shortened, would you expect to see increased patella glide or decreased patella glide? Decreased patella glide, because there's too much upward force, right? So if you found that there was decreased patella glide, that's another corroborating factor that your quad is too shortened, and therefore it's pulling up too much. That's why you're getting the compression. That's why you're getting the pain. Now, it just so happens that the quad happens to be lateral to the center line of the kneecap, right? So if it was to shorten, there can't be any shock that your kneecap's going to track laterally. It has nothing to do with the VMO. It has to do with the fact that the quad simply sits lateral to the center line of the kneecap. That's all that is.
Brilliant. Thank you very much, Dr. Yass. You have given us a completely different dimension to the physical aspects of management of the patellofemoral arthritis. That's great. And my name is Rajamani, and I'm a rheumatologist down south here. Thank you very much.
Oh, thank you, thank you. And in terms of, so we're talking a lot about theory here. I would love to get an opportunity to actually just show you guys the actual strengthening techniques, because that's the application. I think you guys would love it. And here's the great part about this. My method allows for me to have a door, a frame, a resistance band, and a chair, and I can strengthen any muscle you want, fully isolated, provide whatever resistance is necessary to get it up to the force requirement needed. And I think that's the final application part of it. Now that you've established that you've got a tight, strong quad and you need to strengthen your hamstring, you're going to have to really understand how to strengthen that. And ultimately, it does have to incorporate progressive resistance. So given the chance to show that, that would be a fabulous thing. I'd love to do that for you guys.
Thank you, Dr. Vikram. Thank you.
Yeah, thank you, Dr. Yass and Dr. Rajmani for your questions. Dr. Yass for a wonderful Dr. Yass for a wonderful presentation. Definitely, we will keep in touch with you and organize more talks with different parts of. Now we have covered the lower back, maybe the shoulder and other places in the future.
Absolutely.
Yeah, we'll get back to you. Thank you for taking time, and thank you everyone for being part of this talk today. I think we'll end it here. And thank Gupta for their for sponsoring the presentation today. Thank you once again.
Thank you.
Thank you. And could you please just send me a copy of this? You said you were recording it, correct?
Sure. Definitely, we will do it.
Okay, great.
Okay. Yeah.
Great. Thank you.
Thank you.
All right. Bye-bye.
Bye.